Thank you for joining me today. In this video, you will understand the core psychiatric drug classifications. We will go over antidepressant, antipsychotic medication, mood stabilizers, anti-anxiety medication, sedatives, ADHD medication, and dementia medications. We will analyze the complex clinical case study with comorbidity. You will learn how to work through a realistic patient scenarios where there is a more than one problem at the same time. This goal focuses on integration multiple diagnoses and understand how they interact. We are going to apply a critical interventionist and diagnosis formula skills. This helps build acute care and patient safety decision-making skills. Develop comprehensive treatment and relapse prevention plans. You will learn to create complete care plan that include psychotherapy, safety planning, behavior strategies, community support. Relapse prevention include routine injection scheduling, coping skills. This teaches long-term management, not just symptom treatment. In this video, I will go over the 5 case studies. I will go over the presenting symptoms, treatment plan, medication that you will use, also the comorbidity that they have. This is 5 clinical study. Each one has 2 or 3 comorbidity that affect their treatment outcome and the symptoms. I will go over the other alternative medications, monitoring plans, relapse prevention. I will go over the education that you want to give and you want to exams you have to use, like you want to assess the alcohol exams that you can use for alcohol assessment. You want to use also I will go over BHQ9 for depression. I will also go over alcohol assessment. I will go over in this video, I will go over also psychiatric medication and mood stabilizer. I will go over depression medication. I will go over, as I mentioned, the anxiety medication. I will compare the psychiatric medication first generation. Why do you choose the first generation then the second generation? What is the risks? Also, I will go over the neurotransmitters that they affect, side effects you have to mention or go over or watch for. So stay tuned and please subscribe the channel. Thank you for tuning me today, and I will continue the lecture. Thank you. Our first clinical case study is 35 years old female with depression and alcohol misuse. She has suicidal ideation. This 33 years old female, she is having a severe depression and uses nightly alcohol. She has also that lead to significant impairment. She has a multiple depression symptoms nearly every day. So she's depressed every day. She is using alcohol nightly. She is having a suicidal ideation. She has a risk for suicidal, high risk for suicidal, and she needs for prompt treatment that include medication like the SSRIs, SNRI, and safety assessment. After we assess her, she scored her depression. The scale is BQ9. She scored at 22, which is severe. Alcohol assessment, which she scored at 20. She scored at 18, which is severe misuse of alcohol. She has a passive suicidal ideation. So plan is SSRI, MI therapy, reduce alcohol, relapse prevention, and triggers, and coping skills. We want to improve her coping skills. We want to plan for relapse prevention. We want to treat the symptoms for the depression with SSRI and MI therapy. And we want to reduce the alcohol misusage. That is a plan for this case study. This is clinical case study, and it has planning, it has prevention, it also has a treatment. So you assist the patient, you will plan for crisis planning. Before you even think about, you have to think about the safety. When you assist the patient, you have to think about the safety. You want to think about the treatment. So if it's safe to treat outpatient, you have to plan the crisis planning, or you have to admit patient like this scoring this needs to hospitalization, because that is the safety way to do that. That is the safety way of monitoring the safety treatment plan. Also, you will know if the patient is taking the medication, so it's safe control environment. So this patient needs hospitalization because she needs the hospitalization because her depression is high, her misusage is high, she is also having a suicidal ideation. All these three things is saying that she needs inpatient. So if you are primary care or outpatient, you have to admit this patient in hospital safety environment that you can control the alcohol. You can make sure she's taking her medication. You want to make sure she's safe. So that is why all this area you have to know that and plan for it and control the situation. In this slide, I want to explain more the BHQ9 and AUDIT assessment tests and assessment scales. BQ9 score ranges from 0 to 27, and it assesses depression scale. It's a depression scale. You want to know how high is the depression is. When I assist the patient in my hospital, I ask them how high the depression is, and this is the scale we use daily. So 0 to 4 is a minimal depression. 5 to 9 is a mild depression. 10 to 4 is a moderate depression. 15 to 19 is moderate with severe depression. 20 to 27 is a severe depression. This patient has a 22. That means she has to be inpatient. AUDIT score is assist alcohol and how often you drink. So 0 to 7 is a low alcohol risk drinking. 8 to 15 is hazardous usage. So it's bad usage. It's not healthy usage. It's risky. It's not low risk, it's higher risk. 16 to 20 is harmful usage. Clearly is alcohol related problems. So you have a problem. You have, even if you are 8 to 15, you have an issue. You need assessment. You want to go to alcohol, or the patient need to be assessed about that and educated for that. They have an issue. 20 is possible dependency, and likely alcohol usage usage disorder. So if the patient is scoring 20, is they have a dependency, so they need to go treatment. 16 to 19, they also has an issue. Clearly they are related. They have a problem. They have pancreatic inflammation. They will develop pancreatic inflammation, liver cirrhosis. So they have an issue. So they need treatment. Obviously, this patient score 18, which indicate clearly alcohol-related problems. Mentally, physically, it will affect the body of the human being. So she needs treatment. So this patient have BHQ9 of 22 and AUDIT of alcohol usage 18, which is harmful usage. She has a nightly alcohol consumption. That is lot. Depression and suicidal ideation with alcohol, that is lot. This combination increased the risk and justified safety planning and treatment and relapse prevention strategy. That is why you want to have inpatient. That is why you want to involve psychiatric, you want to involve treatment, alcohol treatment. You want to have, that is, this patient is it needs justify inpatient and safety planning. That's why she needs that, because it's a lot for her safety, lot for her body and mind, lot for her treatment. If you are impaired, you cannot continue the treatment. If you are impaired, you can't know what is safe for you, and that's why she needs inpatient treatment. Our second case study is a patient who has a bipolar 1 plus PTSD and domestic violence risk. Patient present with manic symptoms, no sleep, impulsive and irritable. These symptoms indicate acute manic, which impairs judgment and increase impulsive or risky for behavior. Manic can worsen trauma-related symptoms and induce the patient's ability to stay safe. So it will reduce the patient's safety. It will worsen the trauma that the patient has. The patient already has a PTSD, so that will make it worse. Also, the patient has a bipolar. All this increase the risk of the patient and the people who are around them. So, PTSD, also the patient have flashbacks and hypervigilance. PTSD increases the anxiety, startle response. It has a startle response, emotional reactivity. Combination with mania, PTSD can escalate into hyper-irritability, poor emotional regulation, difficulty assessing a danger. Crisis assess the IPV safety, provide a resource. Clinicians must immediately assess an acute danger level, determine if the patient has safety place to stay, provide IPV resources, crisis numbers, shelter if they are homeless and don't have a house, emergency service as needed. If the patient's safety and others are in risk, and if the patient are not taking their medication, that justify inpatient to have the safe environment. Treatment plan include lithium or valproic to stabilize the mood during the acute manic. Avoid antidepressant until the manic is under control. They can trigger or worsen a manic symptoms. So antidepressant medication can worsen the manic symptoms. Immediately assess for domestic violence risks. Provide shelter, crisis contacts, or potential need for emergency intervention. Mostly patient who has a bipolar, PTSD, domestic violence risks, they need inpatient assessment, inpatient hospitalization. Relapse prevention plan include sleep routine, early manic symptoms or signs, sleep routine, sleep dysregulation triggers manic. So patients, when they don't get enough sleep, that trigger manic episodes and acute manic. Monitor early manic warning signs. If the patient is, let's say, shelter or group home, you have to monitor manic signs. This case involves a patient with 3 interaction clinical problems. Patient has a bipolar 1 disorder, acutely manic, post-trauma stress disorder, risky for inmate, partner violence, domestic violence. Each condition is impact the others, creating high-risk complex crisis scenario. So as we mentioned, bipolar itself, patient when they have a bipolar itself can affect how the patient can use the treatment. They will have manic. Bipolar has a manic episode and depression episode. So if the patient is manic, it's hard for them to take their medication. It's hard for them to see the symptoms. It's hard for them to seek treatment. It's hard for them to communicate their needs, to function as a normal in the society. If they also have PTSD, that increase the risk. If they have a domestic violence risks, that increase risk to their safety, to their treatment, to their function. So they will have, they could not function normally. Our third clinical case study is a patient who has ADHD, anxious, and thyroid abnormality. All these case studies, they have multiple comorbidity. That is why I choose them. They affect each other. So this patient presenting with overlapping symptoms, inattention, panic, and fatigue. After assessment, you find out abnormal thyroid function. Patient has a ADHD positive symptoms. Clinical reasons include treatment thyroid first. So first you will treat the thyroid, and then untreated thyroid disorder can worsen ADHD symptoms. It increases the anxiety. So you want to reduce the medication effectiveness. This reduces the medication effectiveness, create unstable mood and energy levels. So these symptoms, they worsen each other. After you assist the patient, you find out that the patient has a thyroid abnormality, they have ADH positive, they are positive, and the clinical history is you want to treat the patient's thyroid first. You want to treat the thyroid first. Untreated, because untreated thyroid disorder can worsen the ADH symptoms. It will increase the anxiety. It will reduce the medication effectiveness. Create unstable mood and energy. You will have a low energy or you will have a high energy. This one has a abnormal energy level. Plan is you want to give atomoxetine plus SSRI, and then therapy, CPT therapy, and then you want to plan relapse planning. You want to prevent this happening again, so you have to plan for relapse. Routine symptom tracking, and then you plan routine symptom tracking. So as we mentioned, when the patient has abnormal thyroid symptoms, ADHD symptoms, anxiety symptoms. You have to treat each separately, but also you have to see the big picture. You want to treat the anxiety, you want to treat the thyroid abnormality, you want to treat the ADHD symptoms, so you can stabilize the patient. Also, you want to track the outcomes. You will check the thyroid labs. You want to check if the patient improving, anxiety is improving. You want to check if the mood is stable. You want to check if the energy is normal and normal level. You want to consider all that. You want to plan for that. Our fourth clinical case study is a patient with psychosis, risk of homelessness, and non-adhesive to the medication. Patient, when they have a psychosis, they cannot take their medication. They are not aware. And they also have a risk of homelessness because they cannot work. Somebody who having a psychosis cannot work. So that is the case study I have here for you. Present symptoms include hallucination, disorganized thinking and behavior. And these are the hallmarks of the positive symptoms of psychosis, which impair function and judgment. Yes, these impair the function of the human being and judgment. They don't have a good judgment to take medication. They are impaired. They are in psychosis. They are not here with us. So crisis impair. The crisis symptoms that they have, they are impaired with ADLs. They cannot take care of themselves. They need a hospitalization for the psychosis. It's difficulty maintaining housing because they are not working, they cannot pay their rents, they cannot function normally. They have a poor hygiene, they misuse pills, they are unable to access service. That increases the risk of the harm to themselves or to others. They could be victimized because they are behaving abnormal and they cannot maintain normal boundary. The one I saw they cannot maintain the boundary, they cannot take their medication, they are either walking or yelling, they cannot dress appropriately, they are in psychosis. So the plan is hospitalization. They need safety and stabilization. Non-adhesive patients with psychosis frequently stop taking their oral medication. Psychosis, lose their medication, forget their medication or doses. They take either more or less, or they forget at all. Disturbance treatment due to paranoia. They are scared of the medication and treatment. They don't believe that. This leads to worsening symptoms, relapse crisis, higher hospitalization rates. So they cannot take care of selves. Treatment plan include long-term injection, psychiatric medication, social worker for housing and referrals. Common long-term injection psychosis include Abilify, Invega, Risperdal, Cybraxa, Haldol, UDACE, Berser, Suicidal, as we mentioned. Housing is a critical part of the stabilization psychosis. You want the patient to have a safe environment, maybe safe shelter, improve medication adhesiveness, reduce the risk of harm, allows regular follow-up visitors, support long-term recovery. Relapse prevention plan include consistent injection, community support. So the relapse prevention is include taking the medication, patient taking their medications. The patient needs housing, either first hospitalization for the patient to improve the treatment adhesiveness, assessment, planning for discharge, stable discharge, and relapse prevention will include the discharge planning. So you don't want the patient come back to the hospital. Same psychosis. You don't want them to be homeless and victimized. They are risky for harm to themselves and to others. They will not be taking their medication, as we mentioned. They are hallucinating. They are paranoid. They don't think this is safe for them, or they should be taking this medication. They are talking to somebody else. It's not here. They don't trust the medication will treat them, or they don't trust the clinician advice. So they need hospitalization until they become normal and they can manage the psychosis. You will find a safe housing for them, and you will use the long-term injection, so you can schedule the clinic that they can come and get the medication monthly or twice, depending on the medication dosage and clinical advice. Our 50 clinical case study is patient with anxiety, benzodiazepine dependency, and insomnia. So the patient has anxiety. It have been prescribed the benzodiazepine and they become dependent. They also have insomnia. Clinical presentation they are presenting is daily panic symptoms, benzodiazepine misusage that lead to rebounding anxiety, persistent insomnia, worsening overall functioning. So they had anxiety before. That's why they been prescribed the benzodiazepine, and they become dependent on the medication. They are having insomnia. So wherever they feel the symptoms, they take benzodiazepine, and that increase the panic and increase the anxiety and increase the symptoms. This misuse lead to rebounding anxiety because benzodiazepine misuse leads that anxiety increase. They have a persistent insomnia. They can't sleep. They are anxious and they can't sleep. That worsens their overall function. That leads to risk. And risk factors include physical dependency on the benzodiazepine, higher risk of withdrawal seizure if they stop the medication. If they stop the medication abruptly, they can go to seizure. So you want to manage that. You want to lower the dose every week, every day, little bit by little bit, so they don't have a withdrawal seizures. You want to control. So they need hospitalization environment that you can manage the anxiety, benzodiazepine withdrawal, and improve their sleep. So the treatment plan is a supervised benzodiazepine tapering to safely reduce the dependency. You want to taper the medication safely. You want to begin SSRI or SNRI for a long-term anxiety management. Benzodiazepine medication is just a short-term use. It's not long-term use. That's why the patient become dependent to the medication. It is only when they are in the hospital safety environment that the doctor can titrate the medication or manage the withdrawal. Relapse planning or relapse prevention. Avoid all sedative medications, continue regular therapy sessions, and therapy adhesiveness. Patients, when they are anxious and panicking, it's hard for them to have that therapy adhesiveness. Use a structured coping tools for the anxiety and insomnia. After they discharge you from the hospital, before they discharge you from the hospital, you have to plan for their relapse. If you don't want them to have this crisis again, you want to have a follow-up appointment, you want to have where they can go and see the therapist, you want to have support environment outside the hospital, you want to educate them as much as possible. If you see these symptoms, come back. If you see symptoms, follow up with your psychiatry. This is the medication you will take. You want to balance that. You want to have a support around them that can help them and see the symptoms, or if they are taking their medication, if they are sleeping. If the insomnia will increase the anxiety, will increase psychosis, you will increase the paranoia, it will affect their daily function and how they take the medication or how they see that they are having symptoms and they need help. So that's why you want to plan for relapse when they are in safe environment in the hospital, so they can discharge safely outpatient. In this slide, I am going to go over antidepressant medication. Antidepressant medication classes include SSRIs, SNRIs, TCAs, MAOIs, and typical antidepressant medications. Mechanism of this antidepressant medications: SSRIs increase serotonin by blocking the reuptake. SNRIs target both serotonin and norepinephrine, so it blocks the reuptake of serotonin and norepinephrine. TCAs affect multiple receptors, increasing the sedation and anticholinergic effect. Indication for antidepressant medication include generalized depression disorder, major depression disorder, generalized anxiety disorder, OCD, PTSD, panic disorder. Safety consideration include delay onset. So antidepressant medication are not quick because they are not like the benzo. Benzodiazepine you use a short term and quick acting. After you manage the anxiety and the depression, then you switch the patient to SSRIs or SNRIs medication. So antidepressant medication, they have a delay onset. They also affect the GI upset. They affect the stomach. You will have a nausea, vomiting. You will have some of them that you will have weight gain. You will have some of them, they have a diarrhea. Serotonin syndrome risk. They have a serotonin syndrome risk because they increase the serotonin. That you will have discontinuous syndrome. Discontinuous syndrome. When the patient discontinue, they will have relapse anxiety. They will have a symptoms, sexual dysfunction. Antidepressant medication, they have that dysfunction of the sexual dysfunction. First generation antipsychotic medication is they have a strong dopamine blockage that leads to EBS symptoms. They have a high risk for developing EBS risks like the dystonia, akathisia, sedative dyskinesia. Examples include Haldol, fluoxetine, perfenacin, bimoside, tarofloramacin. Adverse effects include acute dystonia, akinesia, sedative dyskinesia. You will monitor abnormal movement. You will monitor and you will use the abnormal involuntary movement scale exam called IMS. Also, you will use anticholinergic medications. These anticholinergic medications are the first line treatment for acute EBS symptoms management. So antipsychotic first generation, they have a higher risk for EBS. That's why the second generation is preferable. Second generation antipsychotic medication is they have a modern dopamine blocker. They block the D2 receptor. Serotonin and dopamine, they are dopamine and serotonin antagonism. That's their mechanism. Their clinical usage include treatment positive and negative symptoms of psychosis, mood stabilizers. They are mood stabilizers. They have been used for bipolar disorder, psychosis, schizoaffective disorder. Example of second generation antipsychotic medication are Risperdal, Cyproxa, Seroquel. They have a low EBS. They increase metabolic risk. They increase the weight. So they have a risk of weight gaining. They have a risk of metabolic syndrome. They have a hyperprolactemia. You will monitor liver panel. You will monitor HbA1c for the A1C for the diabetic. You will monitor the weight gain and you will screen for EBS. So antipsychotic medication, second generation have a lower EBS compared to, they have EBS, but they have a lower risk than first generation antipsychotic medication. That is why they mostly doctors prefer prescribing second generation antipsychotic medication than the first generation, because of the lower risk of the EBS. However, they have a higher metabolic risk. The patient appetite will increase. They will be craving for carbohydrates. They will gain weight. That will lead to diabetic. That's why you want to assess the A1C to see if their blood sugar is higher last 3 months. You want to also do the weekly weights. Also, you want to check the liver panel to see if because they are gaining weight, you want to assess lipid, if they are gaining cholesterol. So, secondary generation antipsychotic medications, they block serotonin receptor, which reduces the dopamine inhibition in the certain brain region. This helps improve negative symptoms like flat affect, social withdrawal, cognitive is more than first generation antipsychotic. They improve the cognition more than the first generation antipsychotic medication. Second generation antipsychotic medication still block dopamine D receptor, but they have a less stronger that leads to a fewer EBS. So the first generation block dopamine stronger. However, second generation, they block the dopamine less, that leads to less EBS. When the medication blocks the dopamine stronger, they have a higher EBS. Okay. So serotonin and dopamine balance leads to treatment, both of the positive and negative of the psychosis symptoms. Second generation is better because it balances the serotonin and dopamine. It treats both positive and negative symptoms of psychosis. It has lower EBS risk than first generation. So you want to monitor mood stabilization in a bipolar disorder. Lower EBS risk, but higher metabolic risk. So the patient will, as we mentioned, the patient will gain more weight. They will develop diabetic symptoms, or they will have, because more you gain weight, more risky you will be to develop diabetic symptoms. And then lipid, cholesterol, that will increase stroke, that will increase pancreatic inflammation. So you will monitor that. You will monitor the metabolic symptoms, and you will monitor mood improvement, function improvement. You want to monitor the outcome, treatment outcome. In this slide, I want to go over mood stabilizer medications. Mood stabilizer medication include lithium, valproic, lamartine. Lithium treat the manic, reduce manic and suicidal symptoms. You will avoid dehydration due to risk of the risks. So when the patient is taking lithium treat manic, acute manic episodes, treats manic. That will reduce the risk of suicidal ideation, but you want to avoid dehydration. You want to encourage fluid intake. Valproic is an anti-agitation, rapidly calming effect. It has a rapidly calming effect that will improve the manic and has teratogenic risks. So it affected the child. If the mother is pregnant, you want to avoid valproic because it has teratogenic risks. However, if you want to test if the patient is pregnant before you prescribe that medication, and then you want to know that you have to know the reason you are choosing this medication. If you wanted rapid calming effect in manic, or the patient is allergic to lithium, that is the second option. Lamartine is good for bipolar depression, focus on risk of a rash. So it has a risk for it has a risk of skin discoloration, rash. So lithium, you want to monitor lithium level. You want to monitor the lithium level because lithium has a toxicity. It has a small therapeutic windows, short therapeutic windows. So you want to monitor that. You want to monitor the LFT, renal function, and kidney, because lithium can affect the thyroid. So you want to test if the thyroid is functioning. You want to know the renal because lithium is excreted in the kidney. So you want to know if the kidney is functioning. You want to avoid dehydration. You want to monitor renal, thyroid, liver panel. You want to assess the renal function. You want to check the liver. You want to check the liver panel, and you want to check the thyroid functioning. For the mood stabilizer, as we mentioned before, it's lithium that reduces the manic and suicidal ideation. We have valproic that provide a rapid calming in manic and mood stabilizer. We have lamartine is the best for bipolar depression, not for manic. So lithium, key risk is a toxicity with dehydration. If the patient dehydrates, that means the level of the lithium will increase. So you want to monitor the lithium level, kidney function, and thyroid function. Fulburic, the risk is teratogenic, so avoid pregnant women. As we mentioned, you want to test the patient before you prescribe that. You want to monitor LFTs for liver function. Lamartine is best for bipolar depression, not manic. Bipolar has depression and manic. The reason is bipolar is one time you will be high in manic and running around and being happy and crazy, and then next time you will be depression, you cannot do anything, you will be function will be lower, and that's why it's bipolar, ups and downs. So you want to monitor. It has a risk of Stevens-Johnson syndrome, which is the skin discoloration and rash. You want to watch for that rash. You want to slowly titrate it. That's what is required. You cannot stop quickly. Monitor needs is, as we mentioned, lithium. You want to monitor the kidney function, thyroid function, for the level. Fulburic, you want to monitor the liver function. That is where it metabolizes. Lamartine, you want to assist the rash and monitor Stevens-Johnson syndrome risks. In this medication, I am going over on the dementia medications. Dementia medications improve acetylcholine level, neurotransmitters helps cognition, memory, learning, and attention. So dementia medication, they improve the cognition, they improve memory, they improve the attention, they improve learning. Some of this medication is here, and memantine, donibenzil, rifestegamine, and calantamine. Those are some of the dementia medications. They reduce glutamate toxicity that help for moderate and severe cases. These medications are used for Alzheimer's and low body dementia, Lewy body dementia. The treatment goal is maintaining function and delay the decline. So they are not cure, but they will maintain the function. You are not going to lose the function that you have when you begin these medications, and they will delay the decline. You want to monitor GI effects and cardiac. It causes bradycardia. Our first effect is GI upset syndrome and bradycardia, so it will lower the heart rate. In this slide is ADH medications. ADH medications are stimulant. They increase dopamine and norepinephrine fast onset. They have a fast onset. Indications include adults with EDH and dysfunction. So the treatment for the ADHD medication include the ADHD and dysfunctional. Non-stimulant medications include atomoxetine, guanfacine. Risk you want to monitor is the appetite suppression. So they lower the appetite. They cause insomnia and cardiac concerns. So they have a risk of cardiac concerns because they are stimulant. They cause insomnia. They suppress appetite. It's like a coffee. You want to monitor blood pressure, you want to monitor heart rate, you want to monitor if they are child, you want to monitor the growth and depression risks. Because a lot of people, they want to take, I have seen people who want to request it, they want to request it from the doctor, I want to take this medication. They want to take the medication because they want to be high. So that's the depression risk that you want to monitor because it like a coffee, it has a stimulant. Some people, they want to function and be quick. So that is the depression risk you want to monitor. In this slide, I want to go over anxiety medications like the benzodiazepine. Benzodiazepine has a short-acting, medium-acting, long-term acting. So I want to go over that in this slide. Short-acting benzodiazepine include Xanax, Ativan, Xerax. That is good for liver impaired patients. Intermediate-acting benzodiazepine include clonazepam. Long-acting benzodiazepine include Valium, Librium, which is commonly used for the alcohol withdrawal, Tarancidine or clonazepate. Indication for benzodiazepine, as we mentioned before, benzodiazepine is a short treatment because it has addiction. People get dependent on that. It has a misuse risk. So it used to acute anxiety, panic disorder, severe agitation. This symptom is you want to give benzodiazepine because you want to control that symptoms. They are not long term, but you want to stabilize the patient and you want to stabilize the symptoms. Then you want to switch to other medications that is long acting and that's safer than benzodiazepine. Muscle spasm. Alcohol, some of the indications include the alcohol withdrawal, epilepsy, but the risk is dependency, as we mentioned, cognitive impairment, and sedation. So benzodiazepine, people get dependent. It has a sedation effect. It has cognitive impairment because you will be sleeping or sedated. So those risky, you have to assess if the risky weigh the benefits. If the benefit overweight the risk. and it has to be short-term usage only, even though they are long-acting, but you just want the patient to use shortly until you switch them to different medications. Anti-anxiety medication like benzodiazepine, they rapidly enhance GABA. That improves mood, that improves or reduces the acute anxiety and leads to sedation and muscle relax. Their indication include acute anxiety, generalized anxiety disorder, panic disorder. Buspirone is the other medication. It's not benzo, but other medication that use the anxiety. It is serotonin partial agonist, lowers onset, no dependency risk. So it's preferable than the benzo. What you want to avoid is patient with substance abuse history. If the patient have a substance abuse history, they could misuse this medication and be dependent on benzodiazepine. So benzodiazepine, you want to avoid the patient who has the substance abuse history. Risk include dependency, cognitive impairment, and sedation, as we mentioned before. Sedative medication is bound to GABA, a receptor to promote sleep. Indication include initiating or maintaining sleep. So this medication are sedative and they used for sleep. They are include sulbidam, Ambien, they include Santa, Lutista. Risky is parasomnia, tolerance, withdrawal, drowsiness, sleepwalking, memory impairment. So sedative medication is used for sleep. However, they have these risks: parasomnia, tolerance, withdrawal, drowsiness, of course, withdrawal, sleepwalking, memory impairment. Alternative medications include melatonin, cognitive behavior therapy for this insomnia. You want to try those before you prescribe these medications that I mentioned here. Takeaways in our lecture include review psychiatric drug classes and their mechanism. The presentation covered the main medications category in psychiatry, include antidepressant, antipsychotic medication, mood stabilizer, anxiety medication, sedation medication, ADHD medication, and dementia medications. We also go over and analyze the complex 5 clinical case study with comorbidity and crisis management needs. This case study demonstrates the realistic challenges and require integrating crisis assessment, planning, diagnosis, and treatment. Creating full treatment and relapse plannings. We go over how to create full treatment and relapse planning. We reflect on how the psychiatric treatment requires long-term planning, not just symptoms relief. We strengthen clinical reasoning skills for psychiatric that reinforce your ability to apply psychopharmacology knowledge to real-world clinical scenarios. So thank you for joining me today. Please subscribe